Welcome back to the Orthopedic Tutor channel. Today we'll be discussing in-depth discussion regarding the median nerve compression neuropathy. This first part of the video will be discussing about the carpal tunnel syndrome, and the next video or the second part of the median nerve compression neuropathy video will discuss about the anterior interosseous nerve compression neuropathy and also the other syndrome, which is the pronator syndrome. Well, let's get it started with the first video, which is the carpal tunnel syndrome. As you can see here that there are certain things regarding this carpal tunnel syndrome that needs to be learned and mastered before you are able to make a good diagnosis, a solid diagnosis, and also treat this condition. Well, basically, you need to know the certain epidemiology that goes along with it. Epidemiologically, this condition is indeed related with certain risk factors such as female obesity, pregnancy, and also hypothyroidism. Be sure to check out my first part of video that discusses compression neuropathy in general, so that you get a good grip on what is going on here. And the associated conditions include these conditions. Well, going on, we need to know that the compression of the median nerve, when situated over at the carpal tunnel, it is called as the carpal tunnel syndrome. But when this part of median nerve is compressed over at the more proximal area, they are known as the anterior interosseous nerve or the pronator syndrome. Now, we need to know that when we talk about the compression neuropathy within the carpal tunnel, there are certain anatomical facts about the tunnel that needs to be learned. The tunnel itself has a borders which goes over at the radial, ulnar, roof, and also floor. The floor of the carpal tunnel is the proximal carpal row. I'm going to show you the pictures here. So these are the floors. It goes through the carpal bones. These are the 4 carpal bones forming the floor. The roof will be the flexor retinaculum, or also known as a transverse carpal ligament, and the radius and also the ulnar border of this. I'm going to close this picture here first. Okay, the radius and also the ulnar border, it goes from the scaphoid tubercle and the trapezium, and the ulnar border, it goes from the a little bit. Okay, so the ulnar border, it goes from the hook of Hammett and also the pisiform. With the contents of the ulnar, the carpal tunnel goes from the median nerve, these tendons, which is the flexor digitorum profundus tendons, the flexor digitorum superficialis tendon, and also the flexor pollicis longus tendon. This content is outside of the carpal tunnel. This is the ulnar nerve. Okay, now that you know about it, next what we need to learn is that the content, okay, I've mentioned this earlier. Okay, now we need to know about the branches. Why do you need to know about the branches? Because these are also frequently asked in exams. You need to know it because you need to identify during your physical examination. There are 2 very important branches of the median nerve that one needs to be aware of, which is the palmar cutaneous branch and also the recurrent motor branch. Do you still remember the sensoric distribution of these nerves that we have discussed in our previous video? I'm going to show you this quick picture here. It shows very well the median nerve, the one in the yellow, and also the palmar cutaneous branch of the median nerve. Well, this branch of the median nerve gives a skin distribution right here, right at the base of the thumb. But there's also the recurrent branch, the motoric recurrent branch, which is this big yellow one. It goes underneath the carpal tunnel, and as it exits, it has various anatomical difference between human beings, and you need to know that because while performing surgery, one needs to be aware of this branch to avoid inadvertent cut of the branch and causing paralysis of the muscles here. And I'll just give you a quick look at what area I am talking about, and it is this area here. Okay, this small area here, these are the ones that I'm referring to. This is the small cutaneous area that is being supplied by the palmar branch of the median nerve. And you need to know that this area might be normal in carpal tunnel syndrome, because as you can see here in this image, that this area is, this part of the nerve goes outside or volar to the transverse carpal ligament, and therefore if you do a physical examination for carpal tunnel syndrome and you are touching the thinner region, then you're probably doing it wrong, because that area may be normal while other area over at the digits will show abnormalities. Now moving on, you need to also be familiar with what we call as a Kaplan line. So the Kaplan line is a line that is drawn along the ulnar border of the abducted thumb up to the pisiform. And this line here helps us identify where the motor branch is. Usually the motor branch or the recurrent motor branch of the median nerve is situated at the intersection of this line and the line drawn from the web space between the index and middle finger. So this little point here helps you identify where your recurrent branch is, and it helps you guide where your needle or where your scissor or your scalpel should be. And you also need to know that the palmar cutaneous branch, it goes all the way proximal around 5 cm from the transverse carpal ligament. Okay, moving on, these are the various anatomical variants that I'm telling you about, because this recurrent motor branch of the median nerve can present as this picture here. In picture A, this is called the extra ligamentous and recurrent type, and these are the most commonly found type. Other type that may be found is the subligamentous type. This is the picture B here. You can see it goes almost directly above the ligament, or it could even be as depicted here. It goes directly through the ligament, or the transligamentous type. It could also come from the ulnar border of the median nerve. You can see here that mostly it comes from the median side or the radial border side of the median nerve, but it sometimes could come out of the ulnar border of the median nerve. Next is that the motor branch can lie directly on top of the transverse carpal ligament. This is very dangerous because as you cut through it, you could accidentally cut this nerve here. Okay, now knowing all that, next we need to know about the pressure threshold. Okay, oh sorry, I skipped this one. This is the normal anatomical innervation, motoric and cutaneous for the median nerve. Be sure to know these muscles because you're going to check for it later on for the thumb functions. Okay, next will be the pressure. So normally the pressure that goes to the nerve is around 2.5 mercury pressure, and when it reaches 20, usually the epineural blood flow has decreased, therefore resulting in edema. And when it has reached 30, the nerve conduction has slowed down. And etiologically, it's basically the same for most types of compression neuropathy. It could be caused by trauma, space-occupying lesion, vibration, and repetitive motions, such as those seen in cycling, tennis, or throwing. For the diagnosis itself, after a good history taking, which involves numbness or tingling in the radial 3.5 digit, which is this yellow area here, remember, not this area but this area, radial 3.5 digit. You could also see that the patient experienced some clumsiness and also night pain, which may awaken the patient. This is quite specific for a median nerve compression neuropathy. Now, there are several specific tests that is associated with it. Those that is named Durkheim's, Fallon, or also Tinel, and also you need to do a Sams-Weinstein monofilament test to detect the cutaneous sensory sensitivity. So for the Durkheim test, basically you do a compressive force directly over at the carpal tunnel, and if the symptoms are reproduced, then you call it a positive finding. For the phalanx test, you usually do a wrist volar flexion for around 60 degree for around 60 seconds. The wrist flexion is usually around 90 degree of flexion. You wait until 60 seconds, and if there's a positive symptom, then we call it a phalanx positive test. And there's also a test called the reverse phalanx test. That is when you do a instead of wrist flexion, you do wrist extension. You put together those two palmar aspects, such as the position of praying in certain religion, and that is called a reverse phalanx position. Next would be the Tinel test, where you do a light tapping over at the compression site, and if there is a reproduction of symptoms, then you call it a positive Tinel test. Additional examination, as mentioned before, radiograph is sometimes not necessary, but this is sometimes also important because some type of carpal fracture can indeed induce acute carpal tunnel syndrome. The signs that you may find in EMG NCV includes EMG pathological findings such as increased insertional activities. There may be some sharp waves or fibrillations, and for the NCV you can find increased latency. Increased latency, that it means that it takes more time for the information that goes along the nerve to reach its normal distance. It takes time, and therefore increased latency. And there could also be decreased conduction velocity. And if you remember what I have mentioned in my previous video regarding basics of compression neuropathy, this conduction velocity is like going through a highway. So the car that goes through this highway has a lower speed because there somewhere along the highway there's a car accident, and the traffic is not as smooth as it should be. So for the histology, your early findings will reveal edema, while the late finding may reveal there is fibrosis, there's vascular sclerosis, and so on. And next, we go on to the interesting part here, which is the management. For the non-operative modalities, it is generally the first line of modalities. You do it with giving NSAIDs and night splint. Remember the thing about the wrist positioning during sleep that I've mentioned earlier. So to prevent that certain wrist position, which is wrist flexion position during nighttime, you need to put a splint so that the wrist is held in extended position. And this is generally, of course, only used in patients with night symptoms. And other modalities include activity modification and also steroid injection directly into the tunnel. The operative treatment should include carpal tunnel release and certain revision procedure if there is any evidence of incomplete release. The carpal tunnel release itself, usually the technique includes internal neurolysis. You also do the tenosynovectomy sometimes, but the indications is only reserved for failed non-operative patients. And the acute carpal tunnel syndrome found in sometimes the distal radius fracture. I'll show you this really good picture here. It shows you that the relation between the Kaplan line and also the different anatomical structures that you can identify intraoperatively. This is the Kaplan line here, the one in the bowl. And if you draw a line here at the web space between the index and the middle finger, you can see here over at the intersection is the recurrent motor branch, which is very notorious. You should know where this is situated at. But over at the here distal palmar arch, you could also see here that there is a superficial palmar arch. I meant a distal palmar crease. You could find here the superficial palmar arch, which is one of the important vascular structures in the hand, and in the borders here at the web space between the long finger and also the fourth and fifth finger, you can see here that there are the proper and common ulnar digital nerve. And also over at the Kaplan line here at the mid section, you could see that there is where the deep palmar arch is situated at. Be sure to know these important anatomical areas, because during surgery you need to have these mapped out on the patient's hand. Now next, for the technique of the surgery, the carpal tunnel release is now very advanced. You could do various techniques including open and also endoscopic release. For the open surgery, which I'm showing you here, you draw a line over at the Kaplan line, and also you take a reference line which is between the third and fourth digit, and this is where your incision starts, and it generally goes proximally. You need to identify the transverse carpal ligament and divide only the transverse carpal ligament. Remember that underneath that ligament you will find many structures, which are the tendons and also the median nerve itself. Be sure to have something that goes underneath the transverse carpal ligament so that you do not accidentally cut through it. Okay, next would be the post-operative things that you need to be aware of, which are the post-operative prognosis and also the complication. Well, the prognosis for steroid injections as one of the non-operative treatment modalities are usually around 80%, and reasons for failure to improve after surgery is one of the indications that this patient might have a bad prognosis, and surgery itself might have less effective effect on this group of patients. The carpal tunnel release itself is also related to the loss of pinch and grip strength, which will in turn regain its original power in around 6 to 12 weeks. The revision surgery provides a bad prognosis because generally after repeat surgery there might only be some relief in around 50% of patient. Now the complication that may arise includes incomplete release, although other complications such as wound infection or other sorts of thing is quite rare nowadays. The rehab program for carpal tunnel release, the good rehab program, should include pre-operative pain distribution documentation, because it helps you determine what happens before and after the surgery. You need to also document the entire upper extremity if necessary, and also post-operatively you need to begin early motion in this patient group. So post-operatively you usually remove the dressing, and around day 2 and 3 you put in a night splint and with the wrist in neutral position for around 2 to 3 weeks for patient comfort, and you can even directly begin range of motion exercises on day 2 or 3. You need to avoid any unnecessary elbow flexion because it may result in irritation of the ulnar nerve, and all those strengthening exercises are recommended on week 4. Next is the restriction. Usually there are no restriction needed for patients that has underwent the surgery over 2 months period of time. That would be all for today's discussion regarding carpal tunnel. Be sure to also check out my other videos regarding median nerve compression neuropathy, which is the AIN or anterior interosseous nerve compression neuropathy, and the pronator syndrome. See you next time. Be sure to subscribe my channel for more videos.